as Jim Rohn said a long time ago, destination determines direction. And I think a lot of times, at least I know in my own personal healthcare career, um, the destination hasn't been entirely clear. I've been Hey everybody, Rafi Salazar here with the Better Outcomes Show. And have you ever thought, or have you ever been asked by anybody, if you look back on your life, your personal life experiences, your professional life experiences, and maybe roles that you've held, can you connect the dots to really understand whether or not there's a common thread or maybe a mission or a calling, if you really want to get high philosophically there, that has led you to maybe the position that you're holding now? Maybe it's a business you've started, a practice you've started, or a technology company you started, or maybe it's just a role that you hold in a health system or a university or something like that. Have you ever taken the time to look back over your career and connect the dots? Maybe you're early in your career right now. Have you ever looked back at your life and thought, why did I end up, or how have I ended up where I am now? Honestly, I don't know if I ever have done that. I was having a conversation the other day with a prospective client. We were talking about a company that they've started, and I was going to help them. I am helping them with some work around their go-to-market strategy and positioning and all that. And I was talking to this client about kind of the mission of their organization, because I feel like that's pretty important to get nailed down when you're talking about kind of establishing the positioning for a solution or a device or something like that, or even an organization. And I was chit-chatting with them, and they said, well, I can see there's a lot of alignment, because I dug into your LinkedIn profile, been following you for a bit, checked out your website, checked out the show, and I could definitely see this common thread through all of your experiences and projects that I think is going to align really well with our mission at this organization, XYZ company. And we were talking about this potential strategy engagement. It's a medical device / solution, software solution. And it's the goal of it, or the target market end user, is patients with chronic pain, which, if you know anything about me, I did a lot of work with chronic pain clinically at the VA and some of my research at the university and all of that. And at first, that's what I thought they were talking about, I've got some clinical experience with chronic pain. I've got some experience bringing solutions like this to market and doing some of the business development strategy for them. Maybe that's what they were talking about. But after we got off the call, and I'm sitting in my office thinking about it, and the comment kind of stuck with me. I was like, I wonder what they meant by that. Is there something that I seem to overlook when I look back at my career and my all the different roles that I've held? Because in my mind, it looks like, I tell this all the time to people, I feel like my resume looks like a case study of a professional with ADHD, right? I've kind of been all over the place. When I describe that to folks, I usually say something like, I've kind of been here, I've kind of been there, I've done different rabbit holes, I've gone down different rabbit holes, I've been on many different teams doing all kinds of different projects. They're all in healthcare, obviously, because I'm a licensed healthcare clinician and professional. And it's true, at first glance, you look at what I've got going on, and I was at the VA doing outpatient stuff, I was in a nursing home for a while, I was a professor on and off, an adjunct faculty, an assistant professor. I was a consultant, a management consultant. I own a practice now. I've been this independent healthcare consultant for years. I've kind of been all over the place. And honestly, when I think about it, when I go back and look at my career as a whole, I don't know if intentionally at the time, well, I know for a fact, intentionally at the time when I made some of those decisions, I was not making them out of this sense of mission or purpose or underlying thread or commonality, right? A lot of times I was getting presented with an opportunity, and I decided to say yes because it seemed like either an interesting opportunity or a potential for advancement. And I'll share a little bit about that here. But what I wanted to do with this episode was kind of use my background as a case study to maybe help other people who are maybe just starting out in their career, maybe make decisions about the next job they take or the next position they pursue, the next role they pursue more intentionally, maybe a way of helping folks that are maybe midway through their career, or in like someone like me, maybe 12, 13, 14 years of experience, kind of tie the thread so that you can make better decisions around the projects you take, the roles that you accept, etc., going forward. Because I think, as Jim Rohn said a long time ago, destination determines direction. And I think a lot of times, at least I know in my own personal healthcare career, the destination hasn't been entirely clear. I've been making decisions, at least I thought I was making decisions because of an opportunity or this, that, and the other, but there were times where I turned down opportunities that seemed like very, very good decisions from a career standpoint, and something just felt off and I didn't take them, right? And I thought at the time, I had this intuition that it was not going to be a good fit, so I didn't take the job. But maybe, looking back now, maybe those positions that I turned down, or those opportunities that I turned down, didn't fit in with the thread that I discovered for myself. So we're going to walk through kind of my thought process, looking back through my own thought processes here, my own career, and how some of those roles and opportunities kind of morphed into what I do now. And then we'll kind of talk about, well, maybe there's a way, some learnings here for maybe those of you that are, like I said, earlier in your career, that are looking at making some moves over the next several years to kind of build a foundation of professional expertise to either build a business or build a solid career on. Or maybe you're someone like me who's been in the field for 12, 15 years or something like that, and you're maybe considering a big move. Maybe you're considering a career change or direction shift, and you're trying to figure out, how do I make this decision? So this is not an episode that I typically do a lot. I don't know if I've ever done an episode like this, but a lot of what we do here is look at humanizing healthcare, the underlying current of humanizing healthcare, and that's kind of what kind of popped out when I look back at my career. So like I said, I've done a lot of things. I've been at a lot of places. And honestly, when I took those jobs, like I said, or took those roles, it seemed like I was just saying yes to either an interesting opportunity or a cool project or sometimes a cool team. I wanted to be involved with some of the professionals that maybe I interviewed with or that I met with for this project, and that seemed like they had a lot going on and that I wanted to be just part of it, right? But I took the time after I had this client call, and I was like, you know what? I'm going to take the rest of the afternoon. I'm just going to think about it. So I'm going to look over. I mean, I got into the weeds. I was pulling up old emails from years and years ago about positions that I did say yes to, opportunities that I said no to, all of that kind of stuff. And after doing all of that digging, I think I came up with, and I found the thread, which is not going to sound super surprising, I feel like, but it was not one that I thought about, like at least at the time when I was making the decisions. It wasn't a conscious or intentional decision that I was making this choice or this move because it met with, or it fell in line with this thread, this theme, if you would. And this is basically what it is. Like, I want to help humanize the healthcare experience. I know I've said that a ton. I've said that. There was an interview that I did recently for a local podcast here in Augusta years ago, and I remember talking to the host, and I said, I think at the end of the day, what I would like to have happened after my career, after my life, or whatever, we're getting really heady, is that I would like healthcare to be better as a result of me being involved in the industry. And when he pressed in a little bit about that, I said, well, I just want people to feel like they're not getting lost in the system, right? Like, I really feel like healthcare is a human experience, and I want that to be kind of manifested, right? I want that to be facilitated in every clinic, in every healthcare encounter across the globe, ideally. So how do we make that happen, right? I'm a big fan of saying healthcare is a human experience. I've said it thousands of times, I feel like, on this podcast. It's in the book, Better Outcomes, A Guide to Humanizing Healthcare. Like, that is a guide to humanizing healthcare, right? Humanizing the healthcare experience. Everything I've been involved in professionally, looking back now, from being a professor and kind of inculcating students with this idea, to working as a management consultant, helping state and health agencies and stuff like that manage care for individuals with complex medical needs, and even as a practice owner, kind of managing a team and setting the tone for care and the philosophy of care at the clinic. All of that has involved trying to leverage technology, maybe streamline operations. But at the end of the day, I've ended up being in a position where I'm empowering providers to create and to have the space and time to build meaningful relationship with their patients. So maybe if like you're driving even deeper, it's more than just humanizing the healthcare experience, but like really empowering or facilitating, if you would, the development of meaningful relationships between patients and providers. So again, that's like the title of my book, Better Outcomes, A Guide to Humanizing Healthcare, kind of like sits right in that. So at some level, it's like, well, duh, like humanizing healthcare is your thing, right? That's the thing about the podcast, is a lot of your work. But again, I don't know if I ever made those decisions intentionally or like saw that like intentionality. I'm taking this role because it's going to help me humanize the healthcare experience here, or it's going to help me humanize XYZ. I didn't really do that. It was really at some levels like, oh, this is a good, cool opportunity. And it's interesting to go back and look and think, what about the opportunities that I said no to? Were those, maybe they didn't align with that thread, that mission, if you would. And that's why I ended up saying no and jumping over to something else. So I'm going to take a little bit of a time here to talk about kind of just the winding career path that I've had. And then we'll go back into this idea of like, okay, how do we use this to like make better decisions for our businesses, for our careers, personally, all of that kind of stuff. So I started out, as most licensed clinicians do, in direct clinical care. I did a short stint at a nursing home. Technically, I worked for a company, a big medical corporation that was contracted to provide therapy services for a nursing home. And I only lasted there 6 months. But that job was basically, I was managing the OT caseload across a couple different facilities. And in that job, because that's what it was at the time, it was my first job out of school. I didn't know what I was doing. I didn't know what I didn't know at the time. I remember one of the most enjoyable aspects of that job. Again, there was not a lot that I found enjoyable about it, not because I didn't like the patients. The patients were great. It was just kind of the burden of working in a SNF, and like this was back in the day when you had to hit rug units and rug levels. Like if you treated somebody for 428 minutes versus 429 minutes, there was like this big spread in money, and so there's all this pressure. I was getting calls and texts from my supervisor who, like on day one, I think I told this story before. Day one as an OT, I walk into the facility and they're like, my supervisor says, okay, we have a problem. Last week, the therapist that you're replacing completed this eval, started this eval, but didn't sign it. And obviously there's no plan of care. And there's something about when the money had to be, or when the claim had to be signed to get some kind of level of reimbursement or something like that. And she said, so what I need you to do is just go in there, sign that note, and then you'll see this patient today for an hour or whatever it was. And I was like, well, I can't do that because I didn't complete the evaluation, and I did not I wasn't even working for you at the time of this date of service. I can do the evaluation today and kind of get them started on a plan of care. And for some reason that wasn't, I don't know if they had like people treating this individual while I wasn't there. This was the red flag for me. And they're like, well, you're a team player, right? And anytime somebody says that, it's always like, let's get ready to run for the hills, right? So I was like, well, I'm still not doing that. So obviously it started off as that was a rocky. I mean, I went home that day telling my wife, like, I made the biggest mistake of my life going into healthcare because of this interaction. But back to the point, the most enjoyable piece of that job was that there was one of my codas that was there, and one of my assistants, Dwight, was this older guy. He had been in the military. He was trained as a occupational therapy assistant in the military, then retired. He was working, I think, a few days a week, basically because he didn't want to be bored. And he loved gospel music. And we would do an ADL group with a bunch of the residents at the nursing home, like Wednesdays at 6:30 in the morning. I mean, it was early. But I didn't mind because I'd start at 6:15 and I'd get done by 3ish or so. My wife was working as a teacher, and we were both off at the same time. But some of the most enjoyable times of that job were going in at some odd hours in the morning to do this. It was an ADL group, and it was like guys' coffee hour basically. So all these old gentlemen would wheel down the hallways, and Dwight would have the gospel music blaring, and we'd have coffee going, and we'd be, if this person's goal was maybe they had a CVA or a stroke or something like that, and we're going to work on like food prep or something like that. Okay, so we're going to get you in here, and we're going to make the coffee this morning or whatever. And they were just good times. And the reason that they were super enjoyable was because we were making relationships with these individuals, these people, these patients, residents that were at the nursing home, and the relationships that I had with the team too. So despite even being under this pressure and not having this boss who was trying to like borderline make me bill Medicare or convince me to bill Medicare fraudulently, there was still this relationships that were being built, these relationships that were being built with the team and with the patients that I really valued. And I remember one patient in particular was an older gentleman, and I had seen him actually on a level 2 rotation, so a clinical rotation before I was a licensed therapist in the hospital. He had a CVA, and I saw him later in the nursing home as now a new grad basically, and was talking to him shortly before he passed. He actually passed away while I was there working in the nursing home. And he said something like, he had a lot going on. He was estranged from his family and stuff. Had now found himself in a situation where he was in a nursing home without a whole lot of social support, and just a sad situation, right? And I remember talking to him at one point. I was trying to get him up and moving for maybe in prep for PT to come in and grab him or something like that for a treatment. And he like stopped and was like, you know what? It just feels really good to have somebody listen. And that was it. That was one of the last interactions we had. A couple weeks later, I went in to go see him, and there was just a group of people around his bed. They had called an ambulance, and he was, I remember one of the other clinicians there saying like, he's actively dying, and he did pass away once the ambulance took him. But that was one of the first early experiences that really formed the way I viewed my role in healthcare as a clinician. Like that my role was not so much to deliver units of treatment. It was not so much to it was not so much about getting the outcome for the patient so much as it was using my relationship with that patient to help them achieve their goals, right? It wasn't about, giving them the exercises to do. It wasn't about giving them the splint to wear. It wasn't about whatever. It was about using our relationship to, in essence, co-create a treatment plan for this individual that was going to get them back to what maybe their prior level of function is how we call it in OT, but maybe it was just like throw the baseball in the backyard with the grandkids. That's an example that I always use, even when I go and lecture at the university these days. Like it was one of those foundational experiences early on in my career that really kind of drove home for me, like really the value that I bring to an encounter with a patient isn't so much the technical knowledge, it's my ability to kind of use that technical knowledge in relationship with leveraging this relationship with the patient to help get the outcomes for the patient, right? And that kind of began forming after that interaction. And shortly after that, I went over to the Department of Veterans Affairs, and I was in their outpatient specialty upper extremity rehabilitation clinic, which was basically fancy for anybody that had an issue from their neck to their fingertips that wasn't solved or addressed by another specialty care came to us. So we would have people that would we'd have vets in our clinic that had seen maybe neurosurgery, maybe pain management, maybe they had a surgery. Orthopedics was a big one. Plastic surgery was huge during hand therapy days, or maybe even the other outpatient PTOT clinics in the other facility. They would fail treatment. They'd go see a specialty provider. Specialty would send them to us, right? And that was another eye-opening experience for me, really just seeing kind of this large organization, because that's what the VA was, right? The Department of Veterans Affairs is a federal government agency, thousands of employees, millions of veterans. I want to say our VA in Augusta serviced something like 300,000 or 400,000 vets, maybe, give or take. Maybe I'm off on that. I don't know. I just remember it being a ton. We saw veterans from like the North Georgia and the Toccoa area all the way down to even from the Dublin VA, because Dublin didn't have, at least at the time I was there, this was 2013, so 12 years ago, didn't have things like orthosurgery and stuff like that, wasn't there yet. So a lot of those vets we saw from basically, there was the Atlanta VA that took like the north and the western half of Georgia, and then you had the Augusta VA, which basically serviced veterans all the way from the south and the eastern part of the state. So we saw a big swath of the geographic population, and as a clinician, it was again, I'd had this experience with this patient in the nursing home that really kind of highlighted to me the importance of like the therapeutic use of self, building a relationship with your patients. And so I'm carrying this into just my daily clinical work as a clinician, and got good. I got some skills with the upper extremity rehab. At least that's what I'm told by patients and stuff like that, right? I like to think that I'm good at what I do. But it wasn't until I began kind of moving up the ranks in leadership at the VA where I realized, like, okay, this is an issue. And the issue was that the organization was so big and so bureaucratic that patients ended up a lot of times falling through the cracks, right? And it was, I'm not going to get too into the weeds about specifics, but there were times where patients were getting bounced around from clinic to clinic, then they'd fall off. We wouldn't see them for 3 or 4 years. They'd come back and for the same thing that wasn't addressed, right? And I remember on a couple occasions, like going to bat for some of these patients to maybe push through some of the red tape to get them to where they needed to go. And there were a couple patients that said something to me like, you know what, it's different because I can feel that you care, right? Like they would come back and talk to us, and not just me, like I feel like we did a good job at it on our team in our clinic. We had patients that would show up 2 years after we had discharged them just to say, hey, show us how their shoulder was doing after their total shoulder replacement, or just chit chat with us. I was in the VA, I was in Augusta, from the Athens CBOC or whatever, but you treated me a couple years ago, wanted to pop by and say, hey. And we built these relationships with these patients that were really foundational to getting them sometimes help that they needed, right? Like there were some instances where a PCP might have recommended maybe a veteran with PTSD, for example, to go get some professional support through psychology or psychiatry or something like that, and they were very resistant to it until one of our team members said, you know what, maybe that's not something that's a bad idea. Maybe you should go look at it. And not that it was like we convinced them to do it, but there was a relationship there, and they were less defensive about it because there was this relationship. And then as I kind of got higher in the leadership roles of the VA, kind of moving through their executive series or whatever, their leadership development programs is what they were called at the time. It became very apparent that the real issue at that big organization was that you had people at the top who were making decisions that impacted real lives at the bottom, but they were not, the experience and the perception of those real lives being impacted was not taken into consideration by the people making the decision. That's very convoluted, but basically what it meant was there was some MBA somewhere who was Lean Six Sigma certified, who was, Lean Six Sigma is like, this project management and efficiency and operations and all that, very much an industrial model of how you improve patient throughput, for example. And you basically run the organization based off of spreadsheets and statistics and benchmarks, almost like you would a car factory, right? Like, we're not producing enough cars, we're not riveting enough, bolts or whatever it is. We need to up we change these two things around and we can get so many more numbers out, right? And not that that's entirely inappropriate. You obviously need to run the organization in a way that's financially stable and soluble, but oftentimes what happens in big bureaucratic organizations is that these decisions end up getting made without any direct input from the people that they're going to affect, both the patients receiving care, but then the direct boots on the ground clinicians that have to then carry out these directives. And that was one thing that was like very apparent after doing a couple of these projects, was like, why aren't we talking to the clinicians in clinic A about making this choice? Because they probably, or this decision, because they probably have an understanding of their patient population, about their workflows, whatever. And it just wasn't taken into consideration. So because of that kind of thing, I was like, okay, I need to get into an organization that just is, at the time, I thought it was just cutting away with red tape. I didn't want to be involved in red tape, bureaucracy, and all of that. In the meantime, I'm like carrying all this into the courses that I'm teaching at the university. I had started teaching evidence-based practice and I think kinesiology and like adult rehab and stuff like that. And so I'm kind of bringing these stories to students, like our job is to, and even back then I was saying our job is to build relationships with patients and leverage those relationships to, achieve meaningful outcomes. Well, then in 2017, I'd graduated in 2012. So this is 5 years later. I'm kind of feeling like it's time for me to move on from the VA, basically because I thought at the time that it was just this bureaucratic nightmare I was trying to get out of. I don't like the bureaucracy. Really what it was I was tired of working for an organization that was making decisions that was dehumanizing the healthcare process, right? I don't think I would not have been able to articulate that in 2017 when I made the decision to leave, but now looking back, it was very clear. So anyways, 2017 rolls around and I get a cold DM from, this is the early days of LinkedIn, and it was a guy named Derek looking for an occupational therapy consultant in Augusta, Georgia, in Georgia in general, to do this project with the Department of Behavioral Health and Developmental Disabilities. And I think I've talked about this work before. One thing led to another, and I was just floored by the opportunity. So basically there was a management consulting firm that was helping DBHDD here in Georgia transition individuals out of state institutions and state hospitals and providing supports for them in the community. So these were medically complex individuals. We did everything from adults with intellectual and developmental disabilities to folks with psychiatric and mental health disorders that were coming off of like forensic units in state hospitals. And we were charged with kind of doing a lot of things for the state. One of the big things we did was kind of establish case management protocols. We did provider readiness and recruitment in the community, so training, ensuring that these individuals were getting the support that they needed. We interfaced with, Georgia called them support coordinators, but they might be considered like case managers and stuff like that. And that was probably, I took the job because a couple reasons. One, seemed like a once in a lifetime opportunity. How many people do you know that have helped, at least like clinicians, like an occupational therapist like me, helping deinstitutionalize individuals is huge. Like that's a pretty unique role. I've only know of a handful of us that have been doing that kind of work, or that have done that kind of work. So I saw it as like, this is a pretty cool opportunity. And then the other thing, once I got into it, was just seeing the team itself was a bunch of high caliber, accomplished professionals who had a heart for dealing and serving people with complex medical needs. And it became very apparent, like even on day one of that orientation, like this is more than just a job for these people. They really care about these individuals that we're helping get out. And in like Derek was a big fan of saying that we're helping these people get a life, right? Like we're helping them stop becoming a number on a spreadsheet, or a patient, or a resident, and being, John or Rafi or, Courtney, whatever, and having inclusion in the community. So I did that for a number of years, and some of the things that kind of helped me. It was funny. I did some of the training at the VA on project management and policy analytics, and what was the other one? Some change management stuff that we did, process improvement and operational work that I did at the VA through some of these leadership development programs. Made me an attractive candidate for the consulting firm. So one thing led to another. I kind of rolled into that position and did that for a number of years, 4 years or so. Well, middle of 2017 to 2020, so three and a half years, give or take, and did that really as again, because in my mind it seemed like a once in a lifetime opportunity. It was a really, really cool project, and the team was amazing. Love those people. If any of them were to call me, I've said this before, like if any of them were to call me and need anything, I would be willing to jump on a plane and go help them. Just good folks to work with. And that's probably one of the driving factors that kept me there for a while, was that the team was just awesome to work with. And then building relationships with these individuals that we were transitioning out was awesome as well. But that job in particular, that role, really highlighted to me that the impact that a caring professional can have on individuals going through health systems, regardless of whether or not they're veterans going through a complex medical bureaucracy, or a patient without health insurance is going through a regional health system, or in this case, really individuals that had no way of advocating for themselves, for supporting them in getting the services that they needed in a way that it preserved their human dignity, that gave them a chance at inclusion in the community. It was just very meaningful work, but it also highlighted to me like how easy people like that get lost in the system. They just become a patient with pervasive developmental delay. Maybe their desires or preferences are overlooked for provider convenience or something like that. And that's something that we very much worked hard to prevent and to kind of combat at the firm when I was working here in Georgia. But it's also something that intuition I also carried into other projects and consulting engagements with other organizations, that this idea of oftentimes, maybe it'll be the title of my next book, the working title is Inverted Healthcare. I was going to call it Bottom Up Healthcare, but someone told me that was to not do that. Thank you, Zach, for telling me that. So I'm going to call it Inverted Healthcare, I think. But this idea of like person-centered healthcare, where we start with the individual in the middle and we build a structure, an infrastructure of support around them, as opposed to what often happens is where you've got processes put in place that prioritize provider convenience or efficiency over patient preference or desires, right? And not, obviously those things can be difficult to align, right? Sometimes maybe a patient wants something that just is either clinically inappropriate or just unfeasible for the operational structure of the organization. Totally get that. But this idea that as a default, what we should think as providers, as provider organizations, is what is the like, let's start with the patient in the middle. Let's put the patient in the middle and kind of build the scaffolding of support, the infrastructure of support around them and their unique medical situation, clinical situation, etc. AI and technology is making that become much more of a reality or a possibility. I've been saying for a while now that my belief is that artificial intelligence and technology aren't going to do so much to like remove healthcare providers from the workforce or like replace us, take our jobs away. But what it's going to allow us to do is deliver hyper individualized care to people that need and want our services, right? Like that is the power of technology in my mind. So we were doing that, not the technology piece, but we were trying to build these systems here in Georgia through the firm around this idea of person-centered planning, patient-centered care, all of that kind of stuff. And it was really meaningful work. So about the time when I was doing some of my independent projects with, maybe clinics or technology companies near 2018, 2019, that was one of those things that became more of a core component of what I was doing with all my clients, was looking at this idea of, okay, how is what you're doing, your solution, helping a provider make a better relationship with the patient, or improving access for a patient to have better relationships with their providers. And that's kind of what has driven a lot of my independent strategy consulting since 2017, this idea of what can we do, how can we leverage solutions or processes to make the human connection, make the human relationships between providers and patients effective, right? Basically, we want to align things like technology and processes with the human needs of receiving care, right? And then obviously, practice ownership was one of those things that kind of presented itself in 2020. And it was one of those, it's funny, I'd always thought, my grandfather was a vascular surgeon. I know I posted about him, maybe talked about him a little bit. And I remember going up, he lived in Ohio, we lived in Augusta, Georgia. And I remember driving up there and spending summers with him and being in his practice, because he was still practicing. He had his own private vascular surgery practice. So he would do rounds at the hospital. He had his own clinic. And I remember him telling me on multiple occasions that he did what he did to earn a living, not to make a job out of it. And as I got older, I kind of asked him a little bit more about that. And he said that, he very much saw his role as a vascular surgeon, as a doctor, really in a vocational way, that he wanted to make these, he had these relationships with these patients, and his goal was to help them live better, healthier lives because of the service that he was providing, right? And I had always liked that. Maybe it was super idealistic, this idea that I liked that the fact that Miss Smith came in and they knew Dr. Lewis, and they talked to him about whatever, their grandkids, what they had going on with their life, how when they were done with this procedure that he was going to do, all the things that they were going to be able to accomplish afterwards, right? So in 2020, after having written about it, talked about it, worked on it in other organizations for a long time, I thought, you know what? Like, maybe I've got what it takes to like start a practice and kind of do it on my own. Not on my own because we have a team here, but like kind of direct the philosophy of care. And over the last 5 years, we've put things in place like we do RTM, remote therapeutic monitoring, not because it's a money grab for us, but because we feel as an organization, me driving some of that strategic decision, that it's just the natural order of using technology to give a clear line of communication between clinicians and patients, right? So we use RTM not because we're hoping to hit it big and be able to bill and make all this kind of money off of RTM, but really because it just makes sense. If Miss Smith wants to reach out to Raffi and say, hey, I've got, I was doing that exercise, I've got some pain right here, what can I do? Yeah, there's no reason why that should happen, why that shouldn't be a possibility. We have like a a four-phase framework for rehabilitation, or a process of care, if you would, that kind of walks patients through like an educational component. We very much feel like some of the value we bring to the table as clinicians is our ability to be knowledge translators within the context of our therapeutic relationship, right? And that's kind of been one of those things we've worked on over the last few years here in the clinic, and it's exciting to see it happening. So again, like you look back on, I didn't even talk about being a professor, but that was like a long winding road of 12 years of professional experience that kind of, if you look at it just on a whiteboard somewhere, like how do you connect these dots? You were, worked at a nursing home, then you worked in an outpatient clinic, then you worked as a professor, then you worked doing management consulting, and now you're a practice owner. Well, the practice owner work, you're kind of doing the same clinical work as you were at the VA, so maybe that line gets connected. I think it's deeper than that. I think for me as an individual, as a professional, that the revelation for me was like, it's all about the human experience of healthcare for me. It has always been that. I think about some of the roles I've turned down, and a couple of them were early on when I was kind of looking outside of the VA for opportunities, and I got interviewed by a guy. He's I don't know what he does now. I think he's a president of some big rehab organization, and took me out to dinner. We had this big, I had met with him and his executive leadership team, all that kind of stuff. And they were very much looking, this was back when mobile Part B was becoming a big thing for Medicare providers. And they were looking to really, in their terms, blow up this region. And they were going to open up so many clinical sites and, all that kind of stuff. And I ended up saying no to that opportunity, not because I didn't think it was a cool opportunity, not because I didn't think there was viability there. I want to say that the person they ended up hiring did very well for themselves. I think they ended up with 4 or 5 of these facilities up under their control, under their management, and they probably made a good bit of money. But during those meetings, at least in my mind, my initial instinct was like, oh, this is like big corporate. This is going to be big corporate down the line. And it was. There's a lot of spreadsheets, a lot of that kind of stuff, which, again, provided somebody a good job. It just wasn't a right fit for me. So I want to be very clear about that. Like, it's easy to make value judgments, maybe fundamental attribution error judgments about different career paths or different ways of doing things. And I know I've said this before about like big chain physical therapy clinics, for example. Like, the reason they exist is because they're meeting some kind of market demand. It's not the way that I want to run a clinic. It's not the way that like the patients that we treat in our clinic want to be treated. But they've got full schedules. So I mean, there's somebody they're meeting some need. Somebody thinks they're doing a good job. So it's not a value judgment per se. When you get to the point of putting financial metrics ahead of individual human needs, then that's a problem, and we can talk about that. But as a general standpoint, like, it's not a value judgment on this person in this organization. When I was interviewing with them, I just felt like it wasn't for me. And looking back, the reason I had that intuition was because it was a high volume. It was a high volume business model, right? Their goal was to crank a whole bunch of people through the process, hire a bunch of people, churn and burn. Provider churn was something they were planning for. Like in my organization, we have had turnover, and part of it's because somebody has decided they're moving, or they had a sickness or death in the family and they had to leave care altogether, or they were, like I said, somebody moved literally across the ocean. But it hasn't been because we've been working people to death under productivity burdens, right? So it's just a different way of running business, right? So that was me, like, kind of connecting the dots over 13 years, that all of these things were really, at least in my mind, the revelation for me was that it really all came down to humanizing healthcare. Maybe I saw them initially as like little rabbit holes I was going down or opportunities I was saying yes to that were neat opportunities. But humanizing the healthcare process wasn't a conscious filter at the time for that, but it shows up in each one of those roles that I've taken, projects that I've worked on, and it shows up in spades, right? And it's kind of built on each one is built on the one before it. Like I said, some of the learnings that happened at the nursing home carried over to the VA, and that carried over into the project management, the consulting work that I was doing with DBHDD, and that has ultimately informed the students that I've taught, the type of coursework and material, the research that I was involved in, but then also the practice and how we run it here now, and even the projects that I say yes to on a consulting basis, right? I'm working with some organizations right now, and it's becoming very apparent now, looking back at some of them over the years, like was some of the driving factors or the common thread between some of those consulting engagements was that they were a tool or a solution that was helping to humanize the healthcare process, whether it be some of these patient engagement platforms that I've worked with over the years, or some of these technology, like these SaaS companies that I've worked with. It's becoming very clear to me now, like this is becoming at this point now, it's a filter that I'm using for new client engagements going forward and maybe new roles down the line. So what does humanizing the healthcare experience mean to me now? Well, I've built 13 years of content on this, more or less, but it's beyond data, billing codes, and protocols. I said that in the book. It's about the lived experience of patients and their interaction with their providers, right? We're changing, or at least the shift in our mentality in healthcare from a transactional model to more a relational model. So obviously, like that, some of that was in the book, Better Outcomes, A Guide to Humanizing Healthcare. Maybe I'll get around to writing the second book in the next year or so, and it'll be called Inverted Healthcare, or Inverting Healthcare, and it'll kind of build on that a little bit more. But why does that matter in today's industry, the healthcare industry? I think obviously, like, healthcare often defaults to checklists and protocols, efficiency, at the expense of empathy sometimes, right? I remember quoting one of the quotes that I put in the book, Better Outcomes, A Guide to Humanizing Healthcare, was a John Bogle quote. And it was from one of his investing books, but it was basically something along the lines of when the financial, I'd have to go back and look at it, but it's something along the lines of like when the financial priorities of the organization outweigh the needs of the human individual, you've got a problem. So that's kind of like looking at the last 13 years of my career, I can see like that has been the through line for all of those organizations. So what does that mean for me going forward? Now that I realize that, obviously it's like it changes my approach to saying yes or no to certain projects. Now I'm evaluating relationships with even vendors and stuff like that to the organization with, does this advance the mission of humanizing the healthcare experience here at the clinic or for patients that are going to be served by this solution that I'm working with? So it helps say no to things that are not aligned with that opportunity, right? So what does that mean for you, the listener? Well, it means that maybe what you should consider doing, or what I would encourage you to do, is to go back and you could do it. I just did this on LinkedIn. I pulled out my LinkedIn profile and just kind of looked through everything that I have on there. But maybe pull up your resume or LinkedIn or something like that, and look at all your roles. Identify the motivating factors that made you take that role, and maybe off to the side. This is what I did. So I had all the list of my roles, and then I had like off to the side, neat opportunity, maybe management experience or something like that. Like look for those themes. Was there anything about that role that you found enjoyable? So the job, the reason for making the decision, most enjoyable piece about that job, right? And see if you can find patterns. Maybe you could journal about it if you wanted to. If you've got a business coach or life coach, I don't do any of that, so don't talk to me about it. But if you've got one, maybe chat with them about it as well. Like, help me, or maybe a spouse or a business partner or a colleague that you trust. say, hey, just look at these 5 roles that I've taken over the last 10 years or whatever. What do you think is a common thread here? I know one of the things that I did early on when I started as an independent consultant, there was I was going through this sales program or consulting program. I can't remember which one. I've done a couple. And the person that was running the program basically said, I want you to look back through your Rolodex and pick 5 or 6 individuals that you worked with in a very close way. Maybe a supervisor, maybe colleagues, people that you worked with and interacted with daily when you were in that role, because this was assuming that you've moved on from a couple jobs. And you ask that person, if you can define what drives me, like if you could have guessed what drove me when we were working together, what would it be? And I did that. And one of the things that did come back in that was that you cared about people. Like you cared about people was 2 or 3 of the people that I had sent an email to responded with that. And again, at the time, I really wasn't thinking about it. I was looking at other things and all the opportunities. But maybe you should consider doing that. Email, if you're a fresh grad, maybe email your professors, maybe email people that you had clinical rotations with if you're in the clinical world. If you're farther along in your career, email or message people that were that you worked with closely, colleagues, bosses, supervisors. And like I said, just put something, hey, I'm working on a self-development project, and I'm just going through and asking people just without spending too much time, don't spend more than a minute or 2 thinking about it. What would you say is the biggest thing that was a motivator for me, or that drove me, or why do you think I made decisions in this role? And kind of see what you get back. And then after you've done that, you've got your list of roles, the reasons you made those decisions, the most enjoyable things about them, and maybe this list of responses from previous colleagues and employers and stuff like that. Try to see if you can connect the dots, if you would, or draw a line, a thread through all of that. That kind of shows you or can kind of guide you in, okay, this is something that like a core value for me. So the next job I take in healthcare or the next project that I work on is going to align with this. Like I said, for me, it's advancing the mission of humanizing the healthcare experience. For you, it might be something different. For you, it might be like, if you're a hand therapist, to revolutionize evidence-based practice in hand therapy. I don't know what it could be something totally different for you. It could be something like work-life balance. I want to be able to work part-time and be with my family. Family is very important for me. So the through line is that I'm choosing roles that really prioritize me being at home with my kids or my family, or having the time to do that. There's, again, no right or wrong answers. I think really the benefit of doing an exercise like this is it helps you identify those motivating factors for you, so that the next role you take, or if you're looking at making changes to your current role, that you're able to do it in a way that aligns with what's going to be ultimately most beneficial for you. So again, that's it. That's all I've got this week. If you like the show, head on over to iTunes, leave us a rating and review. It helps people find us. If you want to learn more about the show, www.betteroutcomes.show is where you can find how to sign up. We'll email you show notes and all that. If you want to connect with me, you can do that on LinkedIn. Just search for Raphael Salazar II on LinkedIn, or RafiSalazar.com is probably the easiest way. All the links to everything is at RafiSalazar.com. If you run an organization or you're putting together an event and you're looking for speakers, primarily to talk about humanizing healthcare and the healthcare experience, you can learn more about having me come and speak at your organization, either in person or virtually, at speaking.rafisalazar.com. Until the next time, folks, be safe, be healthy. I will talk to you then.
Thanks for listening to another episode of the Better Outcomes Show with Rafi Salazar. This episode is brought to you by Strata PT. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how their EMR and RCM works, head over to stratapt.com to book a demo.